We are right, please.
Good evening, everyone. Welcome to iFocus Online, lecture number 538 of Optics and Refractive module number 30. So today's topic for discussion is schematic and reduced eye, transmission in optical media, and Stiles Crawford effect. And it will be taken up by Dr. Kanika Bhardwaj, ma'am. I would like to introduce the moderator for today's class, Dr. Amita Kaul, ma'am. Ma'am has done her MBBS and MS from Government Medical College, Jammu, and has completed a fellowship from Rajiv Gandhi University of Medical Sciences at Bangalore. Ma'am is a university certified cornea and refractive specialist with more than a decade of clinical experience. She has been trained at Narayana Netralaya, LV Prasad Eye Institute, and Shankara Eye Foundation. With more than 12 years of ophthalmology experience, her expertise and interest lies in laminar corneal transplants, lenticule-based refractive surgery, ocular surface disorders, and refractive cataract surgery, with a strong emphasis on evidence-based clinical approach, research interest, and academic education. Currently, she is the senior consultant at Center for Sight, New Delhi. She is involved in teaching and training of DNB students and anterior segment fellows. She has more than 20 peer-reviewed publications on cornea, cataract, refractive, and surface procedures. She has delivered many lectures in various national and international conferences. We welcome you, ma'am.
Thank you very much, dear Sohreen, for this kind introduction. It is with great pleasure and it's an honor for me to be introducing one of the stalwarts in ophthalmology, Dr. Neeraj sir. He is going to chair the session today. Sohreen, can we go to the next slide, please?
Yes, ma'am.
Sir is an MBBS and postgraduate from All India Institute of Medical Sciences, New Delhi. He's currently senior consultant at Center for Sight Eye Hospital, Ajmer. He's also the Vice President of Rajasthan Ophthalmological Society and has served as Chairperson Scientific Committee of Ajmer Ophthalmic Society and Organizing Secretary of ROS Conference at Ajmer. He's one of the pioneers in phaco surgery in Rajasthan and has participated as faculty in live surgeries in phaco and SICS workshops. He's a prolific surgeon and has multiple presentations as faculty in various ROS conferences. He has multiple scientific papers, surgical videos, and instruction courses in various national and international conferences to his credit. And Sir was also awarded the Gold Medal for Distinguished Services in Ophthalmology by the Governor of Tamil Nadu in IIRSI Conference 2014. So we welcome you. I'll now be introducing the speaker for today. Dr. Kanika Bhardwaj is a very, very dear junior, and she's an MBBS from Mohan Kumar Mangalam Medical College, Salem, Tamil Nadu, and DNB from Eye Care Eye Hospital and Institute, Noida. She has done her fellowship in cataract and refractive surgery from the Center for Sight Eye Institute, New Delhi, and is currently working as an associate consultant in CFS in cataract and refractive surgery department. She's involved in training DNB and postgraduate students and also mentoring fellows. She's a recipient of multiple awards at such a young age for Best Video, Best Paper, Best Poster at AIOS, DOS, Women's Ophthalmic Society, SAO, and various conferences. She has also received the Young Researchers Award for her thesis, and she has multiple publications in cornea, cataract, and refractive procedures in various national and international journals. Welcome, Kanika. We're looking forward to having a great class with you today, like it's always the case with you. So we'll start off now, sir, with your permission.
Yeah, sure. See, today's class mainly is a physics topic, but we need to interpret its use and use this knowledge in treating ophthalmic conditions to give best to our patient. So how can we use this in avoiding unnecessary aberrations and diffraction and their ill effects, especially in night driving cataract and choosing the IOLs? So the physics part and all will be covered in this in detail, I think. So now directly to Dr. Kanika Bhardwaj.
Thank you, sir. Thank you, Dr. Amita ma'am, for the introduction. Without further ado, let's delve into today's topic. So till now, we were discussing about geometrical optics. Geometric optics basically focuses on the properties of the light itself as a ray or a photon complex. Now we are dealing with clinical optics, which focuses on the human eye and its function in the form of receiving the light and integrating and processing and forming image. So I'll be taking through the clinical optics sections concerned with the schematic reduced eye, the transmission in various optical media, and Stiles Crawford effect. So like we already discussed, geometric optics, it provides a scientific foundation using rays and idealized systems, whereas clinical optics adapts these concepts to analyze and improve vision in medical contexts. And it also accounts for the complexities of the human eye, which itself behaves like a very advanced optical system. So the optics of the eye refer to its biological system's ability to capture and then focus this light to form images. The primary focusing elements are definitely the cornea and the crystalline lens. The adjustable aperture is made up by the iris and the pupil, and the detector is in the form of retina. So the eye itself functions like a camera where all these functions are taken care of by the various parts of the human eye. So coming first to schematic eye. So basically, what is a schematic eye? It is a mathematical and anatomical model which is used to describe the basic optical features of the human eye. That is, we are now seeing the human eye as akin to a optical system and how it captures and focuses eye, and that has been explained with the help of mathematics and analytics. And this is mainly useful to understand the optics, to understand how the eye functions, and also for educational, clinical, and research purposes. So what it does is it uses some idealized representations which are based on spherical surfaces. It considers that the transmitting surfaces of the eye are basically spheres or lenses, and they have fixed refractive indices, which helps visualize and calculate the eye's properties. So schematic eye is essential because it helps us understand vision pathways, and it simplifies the principle of the optical design, which we can further utilize in designing the intraocular lenses or optical devices, even the retinoscopes and other instruments that we use on a daily basis. It is also helpful to apply the principle in correction of various diseases such as the cataracts, the refractive errors, the aberrations. Basically, a schematic eye is a simplified version of the physics or the optics of the human eyes. So what are the main components? So mainly we have all the structures of the eye which behave as refracting surfaces. For example, the cornea is the major refracting surface which accounts for the majority of the refractive power of the eye, the dioptric power. The anterior chamber is a clear aqueous humor-filled cavity which again helps in the transmittance of the light. Iris and pupil, they control the light entry and behave in part like a shutter. And the lens is itself another lens, the crystalline lens, which works for accommodation and fine focusing, whereas again the vitreous chamber is a clear transparent gel which maintains the shape and also helps in transmittance of light up to the retina. Retina is composed of photoreceptor layer which processes the visual information, and optic nerve then sends the signal to the brain. The sclera and choroid are mainly for the eye support and nutrition. So now what is the purpose? Like we discussed, the purpose of this schematic of an optical system of the eye is to use this as an aid to educate students and to help them learn and practice the concepts of ocular optics and retinoscopy. Of course, the human eye is a complex system, so we need to simplify it in order to understand how the workings are. Then for research purposes, this allows researchers to study how the image is formed and what are the effects of aberrations on the image formation and the quality, and also the impact of refractive surgery on retinal image quality, and for example, intraocular lens designs after cataract surgery. Then engineering and design, these are used to model the advanced and the more premium type of intraocular lenses and ophthalmic devices. So how did the evolution occur? Basically, early models were developed by scientists like Huygens and Smith, and there were significant contributions from Listing and Legrand. But the main contributor to the development of schematic eyes was Gullstrand. Albert Gullstrand created the most detailed and widely accepted and used schematic eye model. He provided precise data for the eye's optical system, and he even won a Nobel Prize for the same in 1911. Now the modern models have been identified and they have been actually derived from the Gullstrand's model based on various modifications, such as in conditions of accommodations, and other incorporating features like the eye's ability to use complex optical simulations. So the newer models are there, but Gulstrand model stands as the standard till now. So there are two categories of schematic eye models. One is paraxial and the other is finite. Now, paraxial is also called a small angle schematic eye model because this only focuses on the line or the rays which are getting focused very close or parallel to the optical axis. So this category of schematic eye model assumes that all surfaces are spherical and it ignores any of the peripheral aberrations, and it limits the accuracy to only the rays which are very close to the optical axis. Whereas the finite or the wide angle schematic eye model is a slightly more complex and anatomically more accurate also, because it incorporates the asphericity of surfaces and it doesn't consider the surfaces to be only spherical. It also considers a gradient in the refractive indices of various parts of the eye instead of considering a common refractive index. So this allows it to predict more accurately the vision in a wider range of conditions, including for those rays also which are off axis and in conditions of larger pupil also. So these are the basic differences between paraxial and finite schematic eyes. Complexity wise, the paraxial eyes are simple to understand, whereas the finite eyes are more complex and detailed. The surface consideration in paraxial system is always spherical, whereas the finite system also considers the asphericity of the surfaces. The refractive index is kept constant for all the media, whereas the finite schematic eye keeps a gradient. Ray assumptions are for smaller angles and only the rays near optical axis in the paraxial system, whereas they are large angled and wide field, and this is actually more closer mimicking to the true optics of the of the human eye anatomically. Aberrations are ignored in the paraxial system, whereas aberrations and the variability of real life images is considered in the finite system. So the purpose of paraxial schematic eyes is only for basic teaching of optics and refraction, whereas the finite schematic eyes is used mostly for surgical planning, research, and lens design because it is more accurate. So these are the two types of paraxial and finite schematic eye examples. So in the paraxial schematic eye, we can consider the reduced eye concept where there is only one refractive surface. For example, the reduced eye given by Listing, Emsley, Bennett, and Rabbits. In the simplified eye, they have added crystalline lens also. So such examples are Helmholtz, Gulstrand, Emsley, Legrand simplified. Whereas exact eyes, they have four surfaces. For example, Gulstrand and Atchison and Smith and Walker. The finite schematic eye, they consider gradient in the refractive indices and they consider the aspherical and curved corneas and the retinas and various axes. So a lot of examples in this as well. Smith et al. Is more famous and there are others also mentioned here, guys. So coming to the standard, which is the Gulstrand schematic eye. So it was first Listing and Gauss's conclusion in 1841. And then Helmholtz held this concept, which was later modified by Gulstrand. So these were the pioneers, but it was Gulstrand who did major work on this. So for a homocentric system of lenses, they concluded that there exist three pairs of cardinal points, that is total 6 points. So there are two principal foci, that is where the image is formed, anterior and posterior to the cornea. Two principal foci, two nodal points. So the nodal points lie anterior to the lens and in the anterior chamber, whereas the principal points are closer to the lens. So all of these positions are defined in relation to the corneal plane or the principal plane. So Gulstrand worked on these and developed the basis of schematic eye calculations, which is used even today, and he received Nobel Prize for the same. It's a gold standard in clinical optics due to the realism and precision in modeling the physical optical properties of eye. So this is a diagram of the Gulstrand's schematic eye model. So we'll go one by one through the cardinal points. So there are two principal foci, F1 and F2. So the foci 1 lies 15.6 millimeters in front of the corneal plane. So if this is the corneal plane, so the F1 lies about 15.6 millimeters ahead of the corneal plane, and F2, which is the principal focus 2, it lies 24.2 millimeter behind the corneal plane. Similarly, principal points, they lie in the anterior chamber. The H1, the first principal point, it lies 1.35 millimeter behind the corneal plane, whereas the H2 lies about 1.6 millimeters behind the corneal plane. So basically, these points are where the light once touches and crosses the cornea, it crosses, and how it focuses and how the image is formed. Similarly, there are two nodal points in the posterior part of the lens. So nodal point 1 is around 7.1 millimeters behind the corneal plane, and nodal point 2 is at 7.3 millimeters behind the corneal plane. So these values were given by Gilstrand himself, and therefore all the students need to be familiar with the values. There were other components also in Gilstrand's schematic eye. So he proposed that the total power of the eye is somewhere around 58.6 diopters for unaccommodated or relaxed emetropic eye, that is non-accommodated eye, from which the cornea contributes about 43 diopters and the lens contributes about 19 diopters. And other parameters that he mentioned was the radius of curvature of the anterior cornea, which was 7.8 millimeters, and the refractive index was kept at 1.377. For the posterior cornea, the radius of curvature was 6.5, and the refractive index was again 1.337. Again, for the lens, there were two surfaces, anterior and posterior. For the anterior lens, surface radius was 10.2, whereas for the posterior, it is a minus meniscus lens, so it's a concave surface, so it was kept at -6. The minus denotes the concavity of the lens. And the refractive index was a gradient, like for the anterior lens and posterior lens, there was a difference in the refractive index. So the core or the nucleus of the lens was higher index, which was 1.42, whereas the shell was kept at 1.386. The vitreous, because it is clear gel, it was given a refractive index of 1.336. So almost a homogeneous system of refractive indices, except for the lens, which had a gradient. Now, what were the clinical applications? First of all, IOL power calculations and cataract surgery. All of these points, the nodal points, the focal points, and the principal points, they help us determine how after a cataract surgery, an intraocular lens implanted will sit into the bag. And this also helps somewhat in predicting the effective lens position post-surgery. Then for contact lens and spectacle design also, like how the refractive errors such as myopia, hypermetropia, they will affect the corneal image or the retinal image formation, and how to prescribe contact lenses and spectacles in order to focus the light better on the retina. Again, assessment of refractive error, the magnitude of the refractive error that a person has can also be determined basis of the image that is formed and by quantifying it with the help of dioptric powers of lenses. To understand the accommodation and presbyopia concept, and for also vision science education and research purposes. Apart from that, certain customization of optical devices such as the retinoscopy, which also uses ray optics, and it also works on the function of reflection through the retinal image. So also aberrometers, they have been designed on the basis of these functions. Now coming to the reduced eye concept. Now, even though the schematic eye concept was simplified version of the human anatomical eye, but it still created a lot of confusion when calculations were done. So then came the concept of reduced eye. Instead of having multiple cardinal points, the points were reduced, and instead of having multiple refractive indices, single values were allotted to simplify the calculations. So there were many people who proposed the reduced eye, Donders being the most famous, and Listing as well. So the need to introduce reduced eye model, it arose from the desire to simplify the complex optical system for practical purposes. So the anatomical eye, we know, consists of multiple refracting surfaces and even chambers, each with its own different radius of curvature as well as refractive index and thicknesses, which created a lot of calculation and complexities in such calculation. So this made direct calculations and understanding very challenging, and hence the concept of a simplified eye with single lens at a fixed distance from a model retina with a standard refractive index and a specific focal length to represent the eye's total optical power made calculations easier, and therefore the reduced eye concept was introduced. So it was Franciscus Donders who first introduced the concept of reduced eye, in the 19th century, precisely to overcome the limits of the anatomical optical models for day-to-day clinical and educational work. Now, this translated a system with 6 cardinal points, which was originally suggested by Gullstrand, to just 3 cardinal points, and which streamlined the study and application of ocular optics. So the key characteristics of a reduced eye system or model is that it has a single refracting surface. Like in the previous model, we saw that both the anterior and posterior surfaces of cornea, as well as the anterior and posterior surfaces of lens, were considered as refracting surfaces to calculate image formation. In the reduced eye concept, there's a single refracting surface. Then there is a simplified optics. It simplifies the complex system into single thin lens with a fixed focal point and a single refractive index, which was kept at 1.333. There were fixed distances, that is the distance from the single lens, that is the cornea was made the single thin lens, and to the model retina was standardized, which was around 20 to 22 millimeters. And there was a standardized power. The total power of the reduced eye model is more often mentioned as around 60 diopters. So like we discussed, there were 3 cardinal points. The typical cardinal points of the reduced eye was just 2 focal points anterior and posterior, and 1 nodal point and 1 principal focal point or the principal plane. So if we understand through this diagram, so there was 1 principal point, which was the corneal point, which was the main point where the refracting surface was mentioned, 1 nodal point, and there were 2 focal points, 1 anterior and 1 posterior. So in this particular model, the anterior focal point was placed around 15.7 millimeters ahead of the corneal plane or the principal plane. And the principal point was actually kept around 1.35 to 2 millimeters behind the cornea in the anterior chamber. Nodal point was somewhere around 7 millimeters behind the cornea within the lens. And posterior focal point was around 24 millimeters at the retina. So in the classic listing model, these are the 4 cardinal points which we've already discussed, and they typically lie at particular distances here. So because of the listing model had a lot of decimal points to them, so then Donders came with an idea that why don't we summarize them and convert them into whole numbers. So the only difference between the listings and the Donders was that Donders kind of changed all these values to more absolute values. For example, anterior focal point he converted from 15.7 to 16, and the posterior focal point he converted from 24.13 to 24. Similarly, the nodal point at 7 and the principal point at 2. Now, what is the clinical application of the reduced eye model? Again, for refractive error study and corrections, for teaching and learning, for retinoscopy and ophthalmic instrument calibration, because when we are doing the calibration of these instruments, it helps to assume the optical system of eye as a single refracting surface. For basic research and optical simulations, and also in preliminary eye models for personalized optical device fits. For example, people who wear loupes for their surgeries or various other telescopic models or other things that they design for their optical devices that can also be calculated with the help of reduced eye concept. Now coming to the transmittance of light by the optical media. So transmittance is basically the property of ocular media to transmit a part of the incidence light. It is basically expressed as a decimal or a percentage, and it refers to the ability or the transparency of any object, and in our case, particularly the optical media or the anatomical parts of the eye in conducting the light and letting it reach up to the retina. So it is amount of light that passes through a biological tissue, lens, or optical instrument, and it is typically quantified in the percentage of incident light. So transmittance T is expressed as the ratio of the transmitted light power to the incident light power, which is T equals to P upon P naught. So key points on light transmittance in optical media. So the ocular media are made in such a way that they transmit maximum quantity of light as much as possible to reduce scatter and to reduce absorption. So this includes the cornea, the aqueous humor, the lens, the vitreous humor. Each of them contributes differently to overall light transmission. The light transmission also varies with the wavelength of the incidence light. For example, the light wavelength in the visible spectrum gets transmitted very efficiently, but that in the UV ray spectrum does not get transmitted because it is harmful to the retina. So that gets absorbed or reflected or scattered. Now, the total transmittance to the entire eye typically is about 80 to 84% in the visible spectrum. That means if there is a light in the visible spectrum falling in the eye, then almost 80 to 85% of it is transmitted through the transparent structures of the human eye. Coming first through the various ocular structures, the cornea forms the first and most important ocular structure when it comes to transmission of light. The cornea is supposed to have a very high absorption, or very high transmission, with absorption as minimal as 10% at the 800 nanometer wavelength, whereas about 20% is getting absorbed and 80% is being transmitted at 400 nanometer wavelength. Anything below 400 falls into the UV category, so that is not transmitted through the cornea. So like I already said, UV absorption, it absorbs over 99% of light at wavelengths less than 300 nanometer, because this is very essential to protect the lens as well as the retina. And there is a wavelength dependence, that is transmission increases when wavelength goes more into the visible spectrum, that is anything beyond 450 nanometers and rising from up to 80% to 94% near the 600 nanometer range, and about approximately 95 to 98% in the 1000 nanometer range. So any change in the corneal thickness or hydration or pathology, for example, change in corneal thickness occurs in various refractive procedures. Then hydration level changes in various diseases such as Fuchs or advanced cases or pseudophakic bullous keratopathy, or any pathology like keratoconus or corneal scars or trauma. Everything affects overall transmittance because this is the first and the most highly transmitting surface of the eye. So this potentially reduces optical quality. So this is just another table format of how the various wavelengths of lights are transmitted. So like I said, UV spectrum, which is less than 300 nanometer, has a very low transmitters, almost negligible. It is highly absorbed, and this has important protective function for the lens as well as retina. Then near UV, which is 300 to 380 nanometer, again, it has a very low transmittance, but gradually increases. The visible spectrum, which lies between 380 to 700 nanometer, almost 95% of it is transmitted. And this high transmission is essential for good quality image formation. The near infrared spectrum also around 80 to 90%, and this also falls in the high transmission category. Coming to the second ocular structure, which has good transmittance or high transmittance, is the crystalline lens. So the crystalline lens also blocks most of the ultraviolet light effectively, again contributing in protecting the retina. For visible light, which is again in the range of 380 to 700 nanometers, the lens transmits very high percentage of incoming light in young adults, and there is about 90% transmittance in wavelengths above 450 nanometer. However, with age, this transmittance decreases, especially for the blue wavelengths, which are in the 400 to 500 nanometer range. That is why with development of age-related nuclear cataract, we see a decrease in the color perception and the saturation in cases of elderly who are developing nuclear cataracts. You might have also noticed that once the cataract is taken out and an intraocular lens is implanted, they start saying कि हमें नीला नीला दिख रहा है, we see more blue from the eye that has been operated. That is because with age, the transmittance of the blue range is so less because of the cataract that once we take it out, the difference is very clearly apparent. Again, the chromophores that develop in the lens, that causes a color change in the lens, and it yellows and browns with age. So the absorption of light is also more. So the contrast also reduces as in when the cataract progresses. Now the lens also filters UV light, but this UV light protection stays throughout all ages, like from young to the old. The UV light is absorbed and it is prevented to reach the retina. So what happens with age on the transmission through the lens? So as the age increases, the transmittance decreases and absorption increases. And this is more particularly noticeable for shorter wavelengths, that is wavelengths close to the blue light spectrum. At 420 nanometers, the transmittance almost decreases by 40% when comparing people aged between 40 to 60 to those turning 60 and older. That is, once you turn 60, the transmittance decreases drastically by about 40% for the lower wavelengths. That's why the blue light is absorbed and not transmitted. For longer wavelengths, which is around 580 nanometer, the yellow-green line, the decline is less steep. There is only about 18% reduction for the same age group comparison. So these changes in transmittance not only affect the quality of vision, but also non-visual photoreceptive functions, because this blue light that reaches the retina, it also helps play a role in circadian rhythm regulation. So this is the clinical aspect of it, that with old age, once the lens starts absorbing more of the blue light and it is not reaching, these patients may have daytime somnolence, and they also may have disturbed sleep patterns, and also their circadian rhythm may be altered. Now, these spectral, how did we come to know that this transmission gets reduced? So these were measured with the help of spectral transmission changes using spectrophotometers on extracted lenses using in vivo methods like the Purkinje image-based technique. So this assesses the lens density and then it calculates the transmission objectively. The other structures that transmit light in the human eye are the aqueous humor and the vitreous humor. As we all know, both of these are actually fluid-filled cavities. The vitreous more into a gel-like format, whereas the aqueous being more into a water-like format. But both of them have high transparency to visible light and near UV above approximately 320 nanometer. They transmit about 80% of more light at wavelengths longer than 320 nanometers. And the aqueous has a very strong absorption band at around 265 nanometers in the ultraviolet range, which is attributed to its nucleoprotein. So not just the lens and the cornea, but even the aqueous humor has a strong support in absorbing the UV light rays and preventing it from reaching to the retina in order to reduce the retinal damage. The important thing is that with age, even though the lens can have lower transmittance, but aqueous and vitreous humor, they do not have any effect of age, and it does not significantly affect the transmittance. Unless, of course, there is any kind of cells inflammation or deposits or vitreous hemorrhage, anything that compromises the transparency of these ocular structures or these media, that can affect the transmittance, but otherwise by itself in an complicated scenario, they have very high transmittance throughout all ages. So why this is there? Because this ensures minimal loss of light intensity when it passes through them to the lens and the retina. So ocular media transparency is very crucial for clear retinal imaging and good visual quality. Any opacity or scattering in these media can reduce light transmission, causing vision loss or distortion. This is also the basis of why a cortical or a posterior subcapsular cataract affects vision quality differently from an age-related nuclear cataract. So we must have seen most of the elderly which have NS3 or 4, but they do not have any cortical component or a posterior subcapsular component. Their vision quality is affected, but the quantity of vision is still there. They can still see about very far away, and they can still comfortably tell you that I can manage all my work without spectacles also. So that is because even though the lens color absorption is increased, but the scattering is not that bad. And so they're able to focus most of the central light that passes through these lenses. So age-related changes, they reduce the transparency in the crystalline lens. And of course, they decrease the light transmission, especially in the blue spectrum, which is contributing to the diminished vision and altered color perception. There is also a test called visually evoked potential. These tests are basically used to clinically assess the functional effect of media opacities by measuring the neural responses to visual stimuli. So in people who have media opacities and we are not able to determine their structural or functional integrity in the eye, so we can conduct visually evoked potential tests to see how to differentiate retinal from other media-related vision loss. Now, coming to the Stiles Crawford effect. So, Stiles Crawford effect is basically derived from the name of two physicists which define this effect. It is basically a phenomena which explains why the directional sensitivity of cone photoreceptors exists in human eyes. Now, directional sensitivity means that the cones that are located centrally, they only central rays can actually activate them and they can perceive color. Whereas those located peripherally, they are directed in such a way to avoid the scattering or the aberrations that are produced from the stray light which is coming from the side. So this is called directional sensitivity. So it is because of the waveguide properties of the cone photoreceptors. That is, they are more efficient at capturing light when it enters near the cone's axis. That is, if a cone is placed in a particular vertical format and if the incident light is falling paraxially to it, then the cone gets stimulated. But if the cone is placed vertical and the light is entering obliquely, the cone will not get stimulated. So this is a very specific function of the cone photoreceptors in the retina. And why this is important is because it helps create a good clarity image and without the effect of peripheral scattering. So the Stiles Crawford effect is actually on the name of two scientists, like I told, Mr. Walter Stanley Stiles and Brian Hewson Crawford. They discovered this effect in the 1920s, and by doing a lot of experiments, measuring luminance sensitivity via light entering different pupil regions using control beams. So they kept throwing control beams of lights to different areas of the pupil to determine how the luminance sensitivity affects them. So there are two types of Stiles Crawford effects, commonly called Stiles Crawford effect first, or the effect of first kind, and the effect of second kind. So the first kind is basically derived or based on brightness, whereas the second kind is based on the color. So according to the Stiles Crawford effect of first kind, any light that is entering near the pupil center will produce a very strong photoreceptor response compared to the same intensity light which is entering at the edge of the pupil, even if we are accounting the size differences in the various pupils. So this peak sensitivity is observed to be very close to the pupillary center, but slightly nasal. So it means that the light which is entering through the central pupillary area will stimulate photoreceptors more and the perceived image will be more bright. In the Stiles Crawford effect of second kind, the perceived color changes according to the light entering the pupil. For example, if a light is entering near the pupil center, then the perceived color will be more saturated, whereas that which is entering at the edge will be less saturated or will create less activation of the cone photoreceptors, irrespective of the brightness of the light that is entering. So why it is important? Because it helps in the assessment of retinal photoreceptor health. That is, if there is any abnormal or reduced effect, this can indicate a dysfunction of cones or the other photoreceptors which is seen in conditions like amblyopia and even age-related macular degeneration. Then for visual quality and glare sensitivity, now the presence of this effect, it reduces the visual sensitivity to light and entering at oblique angles. So when the light enters at oblique angles or through dilated pupil, this generally carries a lot of aberrations or scattering. So if we are able to ignore that peripheral light, which is causing a lot of aberrations and scatter, the image quality and clarity improves. This is also partly one of the reasons why people who have undergone refractive surgery, initially they have a lot of visual disturbances like glares and halos, because now the photoreceptors have to adapt to the new corneal shape. Although this adaptation happens over time, but initially there's a period where in low light or dim conditions, once the pupil dilates, the peripheral aberrations and the light entering through the oblique angles through the pupil does affect their visual clarity. Then this also gives us a good understanding of the surgical and therapeutic guidance. Like, how to understand photoreceptor directionality in optimizing designs of intraocular lenses. So nowadays, the concept is, previously what used to happen was there was only refractive and diffractive design. But nowadays, the newer IOLs are also incorporating the pupillary size into their concept of designing, so that the chances of glares and halos are kept to a minimum when implanting the premium or the multifocal IOLs. Even the EDOF lenses are working on the same kind of concept, where they are independent of pupil size and they help focus the light better without causing a lot of halos and glares. It also helps us evaluating outcomes after retinal surgeries or treatments which are affecting the fovea itself. So thank you from my side. I hope I was able to do justice to the topic. Since most of the topic for today's class is almost something that you have to learn by heart, so I hope it does make you associate things with some interesting clinical parameters so that you can remember these better. The Gulfstrand eye model, the reduced eye model, can be asked as a short question or a long question, the chances being lower side, but still you should know about them.
Thank you very much, Kanika. That was an enlightening class. So, can you hear me? Am I audible?
Yes,
Yes.
yes, ma'am, you're audible.
So, I just have one question about the reduced eye. We discussed both the schematic eye as well as the reduced eye. Now, what are the limitations of using a reduced eye compared to a more detailed schematic eye model? Like you described, you said there is a Gulfstrands model, which is pretty extensive and details everything, right? And then there are reduced eyes, which we use mostly for teaching and all, because that makes things simpler. So when we are looking at higher order aberrations, are there any limitations of using this reduced eye compared to the schematic like Gulfstrands model?
Yes, ma'am. So definitely, if we are using a reduced eye model, because it is considering a single refracting surface and even the pupil size is kept, like the aperture is kept fixed to a small dimension. So this causes a visual field reduction. In clinical scenario, if we compare, there is impairment of the peripheral vision and the field of vision is constricted in a reduced eye model, which does not fare well practically. Secondly, lot of aberrations and other things are negated, which are actually a part of day-to-day life. And even we know that certain aberrations are good for the eye for the depth perception part. So that part is also neglected in the reduced eye model. There is also reduced stereopsis and contrast sensitivity function when we are calculating on the basis of reduced eye instead of the schematic eye. So that is why the reduced eye concept is fixed to certain scenarios related to teaching and some ophthalmic device instrument calibrations, and the more complex calculations are actually still done with the help of the schematic eye models.
So basically the reduced eye, it simplifies the entire eye into a single refracting surface.
Yes.
It ignores the higher order aberrations,
Yes.
it ignores the gradient refractive index of the lens, it ignores the chromatic effects, right? So schematic models include more detail, but basically both of these are approximations because there will always be interpatient
we can
variability,
never actually
interperson.
map the optics of the human eye. It's a very complex structure.
Correct.
But
And person to person, there is variation. Correct. So one more thing, can we, like you were talking about, better surgical prediction, and also, do you think with modern imaging, we can use instruments and, can we individualize these schematic eye models from patient to patient basis for a more personalized
Definitely, ma'am. In fact, the newer models, the newer IL power calculations, even the newer aberrometry profiles, and all of these are actually considering the various models and how the light travels back through the eye. So these are actually already being used to predict better and better surgical outcomes by considering the various aberrations, the various pupil aperture and its effect on light transmittance through these surfaces. So that is already being done, and I'm sure in future we'll have individualized patterns also for each person to undergo. We also have these ray tracing softwares which are also currently available, which help us predict the same, like even before the cataract surgery, we can predict their outcomes with the help of
Right.
these ray tracing algorithms.
So basically, not just cataract surgery, even in refractive
And
surgery
even in
planning,
refractive surgery,
in
yes.
optical research, we can using OCT and aberrometry, we can always personalize these models,
In
right?
fact,
We are already,
OCT
like you
also
mentioned, we are
is a
already
part of
doing
the
it.
same spectrum because
Correct.
OCT also works on the transmittance through various media. So that also gives us a very good idea about the cornea, the anterior segment, even the retina. In the infrared spectrum nowadays, we have very high spectral domain OCT. So they use wavelengths at the infrared spectrum because of the transmittance property of the optical system, which can transmit infrared rays. So we are utilizing that property to help
Right.
with the diagnosis and management as well.
So although primarily, we use these models for teaching, but they are really excellent for conceptual understanding of optics, accommodation, image formation, and we can actually use them to tailor, personalized treatment solutions for patients, isn't it?
Correct.
One question on the Stiles Crawford effect. Now, you spoke about the Stiles Crawford effect, and you said how it happens. It's basically the cone photoreceptors. But can you tell me in one line if there is some way in which the photoreceptor alignment actually contributes to this effect?
Ma'am, I think it is the alignment of the retinal layers by themselves, like how the retinal photoreceptors are placed in the retina, like vertically, and they are more concentrated at the fovea, and then they span out in the periphery. So, in a way, all the light that crosses and reaches through the optical axis directly hits the fovea, where the most concentration of the photoreceptors is there, and they are actually oriented in parallel to the incident rays. So that is why they are stimulated more.
So
That's
basically,
people with eccentric pupils and other problems in the anterior segment dysgenesis syndromes and other, they have a lot of problem because the light that enters the eye is not directly able to stimulate the photoreceptors because of the directional change that occurs.
right. So just one thing I would like to add to that, that cones are basically oriented towards the pupil center. When the light rays hit the eye, they pass through like you said, they pass through the cornea, they pass through the aqueous, through the lens, through the vitreous, and when they actually hit the retina, especially the photoreceptor layer, these cones which are oriented towards the pupil center, they act like waveguides. Light entering centrally is absorbed more efficiently because the distance between two cones is less than half the wavelength of light. So there is a lot of interference happening, but the light which enters centrally, those cones are more regularly arranged on fovea, so it gets absorbed more efficiently. That is why there is that directional sensitivity which happens, and that's how Stiles Crawford effect actually, and we can actually measure Stiles Crawford effect clinically via psychophysical tests. Like, for example, if we shift the entry of light across the pupil, or for example, we have adaptive optics these days. So these are the things that can be used to measure. But yeah,
Yes.
it was a great class. Sir, do you have anything to add to this? Kanika has already done a great job, but if there's anything.
First of all, I'll compliment Dr. Kanika. She has meticulously covered all the details. One, two things I would like to add. One is that in off late we are having a lot of dry eye cases. So, a word about tear film, because in front of cornea is a tear film which we now consider as the first refracting surface of the eye. So that has to be kept in mind whenever we plan for any multifocal IOL or any premium IOLs. And apart from schematic eye, this particular thing has, because it has come newly, so this has to be considered. Second point, word about apodization in Stiles Crawford effect, because in the night time when the pupil dilates, at that time the central rays, because it is the Stiles Crawford effect that gives us a better vision and helps in this particular phenomena of this apodization. Will you like to add something about this on dilatation of pupil in the night, apodization, and Stiles Crawford effect, Dr. Kanika?
Sir, I think we've already covered through the class, and what you're saying is absolutely correct. When the pupil dilates in the night time, apart from the central rays which are passing through, there are also peripheral rays coming at different oblique angles, and therefore they are not able to stimulate the photoreceptors in a way they should, and therefore the image quality, the contrast, the glaring, that increases during the night time especially, and people have more scattering of light through the enlarged pupil aperture. So that also affects their driving capabilities in general also. And of course, after surgery, it increases more.
One last thing
So,
I'll to add is that Dr. Kaul, you are
yes,
saying,
sir. So
yeah,
I
yeah.
was just saying that apodization is actually the reduction of light transmission from center to the periphery of a lens or any aperture. So in like for us as cataract surgeons, sometimes IOLs use apodized diffractive optics. That means the central zones of the IOLs will transmit more light for near vision, while as the peripheral zones, they transmit more for distance. And then there are blending zones in between. At least that is how I have understood it. And this helps reduce the halos and improve the image
There is
quality
actually,
by.
ma'am, an intentional apodization even in the retina also in relation to the pupillary aperture size.
That is what I spoke about when I said the
Yeah.
cones are directionally oriented. That is what I meant. That is so apodization actually artificially reduces peripheral light contribution using optical design. And Stiles Crawford effect, like you rightly mentioned, it is a biological property which causes this kind of apodization. And together, we can actually optimize the retinal image quality by downweighing peripheral light that might induce aberrations or glare. So that is one thing. So I was just, supplementing what you were saying, that it is one thing that is
Absolutely.
already being used in IOL
Yes,
optics these
yes.
days.
So one last thing I like to add is that the point of research now is that the orientation, the anatomical orientation of the cones is slightly different in different individuals. As we know that everything is different in different individuals. That is why, sorry. So that is why the neuroadaptation that we call the aberrations that occur in multifocal IOLs, they occur more in certain individuals and lesser in some other individuals. And then the pupil size again matters here. It is not only the central ring of the multifocal IOL, it is also the Stiles-Crawford effect that affects and the orientation of the cones. I think what we talk about neuroadaptation also depends up to a certain extent on the anatomical distribution of the cones as you are
Cones.
explaining.
That's it.
Do we have any questions from the audience?
Surveen, do we have any questions?
No, ma'am, we don't have actually many questions, but there is just one question, which is basically how do the optical media transmission properties differ in pseudophakia and aphakia? This is the question on our YouTube channel.
Right. So, Kanika, would you like to take that? Then we will ask Sir's expert comments on that one.
Yes, sir. So in aphakic eyes, of course, it's very rare to have aphakia from birth. It is mostly secondary to some trauma or some infection or some iatrogenic activity which compromise the lens and the bag diaphragm. So transmission, if we talk in actual terms, if there was no other complication, let's assume that only the lens was taken away and all the other media were as clear as they were supposed to be. There was no uh, backdrop of nucleus, or there was nothing else, then of course the transmission will not be affected much, because the lens by itself is also a transparent media, although the refractive index of the lens is slightly different. But definitely the transmission property will not be affected much. The image focusing quality will be affected because the lens also contributes significantly to the focal bending of the rays. So that will be affected. However, the transmission will not, which we are talking in an ideal case scenario where there is only removal of the lens. In pseudophakics, again, there is an optical medium, and the pseudophakic lens is calculated in such a way that it helps focus and transmit light intensely into the center of the fovea as much as possible. So transmission through a pseudophakic and an aphakic eye will not be affected much because the transparency remains the same. If other factors are not there, if the vitreous and the anterior chamber have not been disturbed much, but the focusing effect will be different because a pseudophakic eye will be able to focus better, sharper, whereas a loss of about 19 to 20 diopters of focal power from the eye will definitely affect in the vision quality. So the focal nodal point and the focal point will be shifted in that case. Sir, anything that you would like to add to this?
So, yeah.
Yeah.
So,
Basically, see, this is very well explained as far as aphakia is concerned. pseudophakia, we know that there are certain yellow lenses in the market, and nowadays there are certain lenses which are violet light filtering lenses like Technis Synergy and all available in the market. So all these are basically when there is a transmission of light, and we were talking about the absorption of the light. So they are basically a sort of absorbing the blue light also, because it is said that this is having some detrimental effect in the older age group to the macula. So the ARMD can be induced. So that is why these yellow lenses Alcon had introduced. So this is how basically, apart from the transmission of light, the absorption of different wavelengths of light is also different in different type of pseudophakia.
Yeah, so sir, can I just add one thing to that? Like
Sure.
in aphakia, basically, like Kanika mentioned in her lecture, most of the ultraviolet radiation is absorbed in the natural crystalline lens, but which protects the retina. Kanika, I'm not wrong, am I? And
Majority
Even the
is
cornea, even the
contributed by cornea,
cornea is
ma'am, but
cornea is
lens also has a
absorbing.
significant part to play.
so in aphakia, this protection is lost, and UV transmission to the retina increases significantly. And this has been known in literature to cause phototoxicity, glare, or even macular damage at times. When we consider the visible spectrum, the aphakic eye transmits more short wavelength blue light. Okay, so it's like something called a cyanopsia is what happens. Patient perceives a bluish tint in whatever they see. So the overall effect would be more retinal exposure to high energy light, and photosensitivity, and reduction in contrast sensitivity. However, like sir said, the kind of IOLs we use nowadays, they all have built-in protections. So compared to aphakia, pseudophakia would restore ultraviolet protection, and it would there would be some moderate blue light transmission depending upon the kind of filter that is there in the IOL. So there would be that.
Okay,
So,
ma'am.
do we have any other questions?
No, ma'am, we don't have more questions.
Great, sir. So
If you don't have any other questions, I think
can we
can
wrap up the class?
wrap up the class now.
Thank you so much, sir. Thank you for your time. It's
Thank you.
always a great learning with you.
It was really a pleasure to listen to the basics and such meticulously worked up. You must have worked very hard.
Absolutely. Kanika is a known hard worker. Thank you very much, Kanika. That was a great
Thank
class.
you, ma'am.
Thank you,
Thank you
Sureen,
for
for
your
your
time.
support.
Thank you,
Thank
ma'am.
you, sir, for your support as well. Good
Right.
night, sir.
Good night.
Good night, sir. Good night. Thank you.
Good night, sir.